it's always going to start with the current as far as the depolarization happening in this SA node. And the reason it happens in this SA node is because of what's known as a pacemaker potential. So for example, since all you guys are athletes, do your muscles ever do they contract on their own all the time? Or is it because you chose to make them contract?
They contract all the time.
On their own? All of a sudden you just go out for a run while you're unconscious?
No, because we do exercise, so they contract.
Because you're sending the signal from your brain
Yes.
to make them contract. Your heart is different. Your heart has what's known as pacemaker potentials. So what it effectively does is it causes itself to go off on its own. And the SA node happens to go at the fastest frequency. And once that depolarizes, thanks to the gap junctions, it's going to change and proliferate out from there through both of the atria, and actually it's going to be through what's known as the Bachmann bundles, until eventually the signal is going to reach the AV node, because it can't actually go from your atria into your ventricles. There's effectively a barrier where it can't go between. The one little opening is this AV node. It's going to travel through that AV node, down the AV bundle, sometimes referred to as the bundle of phys, down each of the individual bundle branches. They go to each of the individual chambers of the heart, through what's known as the Purkinje fibers, where it's going to fan out and cover a lot more ground through the ventricles and get them to depolarize. Now, your SA node is the pacemaker potential that goes at the fastest rate. Now, your atria itself has its own pacemaker potential. Your SA node or your AV node has its own pacemaker potential. And then your AV bundle has its own, and the ventricle has its own. Now, the key is when the SA node causes itself to depolarize, it causes the rest of the heart to depolarize and causes it to reset. Okay? So if all four of us were to work together and we were to count, and whenever I got to 10, I'd say restart. Whenever you got to 8, you'd say restart. Whenever Caitlin gets to 6, she'd say restart. And whenever Nico gets to 2, he'd say restart. And when we all count at the same speed. So Nico would be that SA node where he's making us restart before we could ever make everyone else restart. Does that make sense?
Yes.
And so if then Nico quit working, aka your SA node quits working, then we'd get to 4, because that's when Caitlin would say restart, and she would be essentially somewhere in the atria that also has its own pacemaker potential. And then and then Caitlin wouldn't work anymore and she'd stop. And then you'd count until you hit 8. And that would be the equivalent of that AV node. And then I would be the slowest one, and I would be who's going off by essentially the ventricles themselves. And so notice that count, that's essentially the time between each beat. Hence, if your SA node's not working, your heart rate's naturally going to be slower because you're depolarizing at a slower rate.
Okay. Okay, thank you.
Hey, so right now, any questions that you have, because obviously last week was weird. I apologize. As you can tell, I kind of have a little bit on my mind. But things are going they're going good, about as good as they can. So do you guys have any other questions over those slides I recorded, since I kind of rattled them off a little bit? Okay.
Can I make you another question?
Yeah, go for it.
There is a graphic on the number, one moment, I'm seeing on the PowerPoint. Well, I don't know where is the graphic, but there is a graphic of the peripheral blood flow. You know that graphic?
The blood flow through the heart?
Yes, and it says like the blood flow increase at the same time at the maximal workload. This means that when you do exercise, because you work hard, the blood flow get increased.
Yes.
Okay.
Oh yeah,
Okay.
very much so. So at rest compared to being at high exercise intensity, sorry, I'm kind of blowing through these slides really quickly. So we can actually show you guys a little bit more of what's really interesting. Is you're going to see that SA note or that stroke volume in general is going to climb rapidly. So especially for like some of the long distance runners that we've got here, their cardiac output. So this is the cardiac output in Qmax. That's the maximal rate of essentially blood you can pump around the body. At rest, they might be sitting at about 5 liters per minute, maybe some faster, maybe some slower. Maximal exercise, you probably got some of them getting close to 40. So the faster we're going, the better job we're doing of returning blood to the heart. So the heart's going to fill more fully each time, as well as the harder the heart is going to contract with force. And that's going to be thanks to epinephrine. And then also just kind of a better stretch of the ventricle from the blood filling. And then the afterload, so the pressure that we're working against on the other side, because blood pressure is kind of going down a little bit on the other side of the aorta, that in turn, all of those combined is actually going to increase our overall cardiac output and the performance of our heart. Okay, so the next component that we touched on briefly, but now you guys can see it graphically, is what's known as the AVO2 difference. Okay, so the red line is really how much oxygen we could effectively have inside of the blood. The arterial content is actually to what level we get. And then the mixed venous content, and notice it says mixed, it's going to drop as we're going up in exercise intensity. So the bigger the AVO2 difference, the better job of we are extracting oxygen from that blood. Now, the reason it never goes down to 0 is because it turns out part of the blood you're going to pump around your body is always going to go to tissues that isn't really using that much oxygen. Now, as we go up intensity, we do a better job of only sending it to the muscles we need to. However, we're still going to be sending a little bit to our skin that's not really using much for metabolism. It's using it more for sweating and other tissues that aren't being that metabolically active by comparison. So as we start exercising, turns out we're going to start losing plasma volume. Okay. Part of it is going into interstitial fluids. That's kind of essentially in between our cells, but we're really losing a lot of it through sweating. And the more we're sweating, the more of a decrease in performance we're going to have. And this decrease of plasma volume, so the fluid component of blood that we talked about earlier, the increasing of our hematocrit. So it's what's known as hemoconcentration. So our blood is going to start to look more like or move a little bit more like maple syrup as opposed to water, which is actually going to make it harder on our heart. And that gives us what's known as cardiovascular drift. So we're going to see a bigger AVO2 difference. So the arterial to venous oxygen levels as we're going to go ahead and increase our exercise intensity because we're doing a better job of pulling out the oxygen we need. Now, we're going to be sweating out a lot, which in turn is going to cause this hemoconcentration. So technically, we carry more oxygen per liter of blood. However, the heart has to work harder to pump it around the body. And our pH is typically going to be going down because we're producing not just lactate, but that proton that comes with it, sometimes referred to as lactic acid, thanks to utilizing anaerobic metabolism, mostly in our type 2 fibers. So now let's talk a little bit about training. So for muscular endurance, we're really talking about our ability to do a movement with a given muscle group and really muscle groups for a relatively short period of time. So this is something that's more about muscular strength and our general anaerobic development. A great example of this would be something like a rep test. So like the 225 rep test in football, or push-ups to failure, pull-ups to failure, something along those lines. Now, cardiorespiratory endurance is our ability to maintain exercise with our entire body. So this is that treadmill test that you guys have done. You can do things that are very similar on bikes. You can obviously even do swimming tests. And this is more about how well developed our body's aerobic capacity and aerobic systems are. So when we're going to look at this aerobic capacity, obviously the VO2 is really useful. It's the total amount of oxygen that someone's going to be able to consume at a given intensity of what they're going to be doing. Now, this is going to be adaptable. We're going to actually be able to increase it. Usually you typically peak out VO2 max in about 6 months to a year and a half with really hard, dedicated training. And obviously genetics are going to be a pretty big component. Now, submax endurance capacity is really important when we're talking about sports, because this is effectively what's the aerobic level that we can keep up for longer periods of time. And it turns out it's really hard to really parse down and what's the most important, because it's always going to be really what matters for the sport. So if you are training, it turns out this is going to go up. Now, when we think about submax endurance capacity, if you are looking at a basketball player, if someone is in really good shape, they can be recovering while they're jogging back down the court, as opposed to they have to be literally dead stop, hands on their knees, catching their breath. Now, for things like weightlifters, throwers, who cares? They can gas out, they'll be fine. But if you're someone that has to go out there and try to pitch a complete game, you're trying to go out there and play a full soccer, 2 halves, you need to have a pretty good aerobic base so you can recover in between those plays and be able to keep putting out really good efforts. And that's where that submax endurance capacity makes sense. So Caitlin, you saw the same thing where muscular endurance sounds more like what a full out is, that 2.5 minutes, giving it all you got. But the kids that were in better shape, those are the ones that will be ready to go full out again in a couple minutes, as opposed to some of your teammates need to lay around on the ground, writhe in pain, and they're not ready to go for a full 10 minutes. And, that's just the way it is. But another insidious thing that you should always keep in mind with aerobic capacity, trust me, I am not a big fan of doing aerobic exercise as far as like my pastime and really what I love to put a lot of intensity into. The reality is the better aerobic base your athlete has, typically the more volume they can do in a given session. So you can do more reps, you can do more attempts, you can do more throws, pitches, etc., and be able to go ahead and recover. And you see the same thing with yourself, Alicia, with track and field sprinters. If you got somebody that's got no aerobic capacity, they might only be good for 1-200 and they're done for the day. So, or if I told you had to do 400 repeats, how much do you hate that idea in the first place?
So much, like I need to train the aerobic capacity, because if not, I don't finish the 400.
And, if that's not your event, then who cares? However, think about it. If I told the cross country team they got to do 400 meter repeats, they're gonna be like, oh, sweet, it's an easy day. But if we to the 100 meter sprinters, they're like, how did I offend you? I'm sorry. I didn't mean to upset you. And if it's the throwers, they're probably just going to be crying or saying, I quit. So, because we've got different amounts of aerobic capacity. So as you'd suspect, guys, as we get to be in better and better shape, our VO2 max is going to go up. And this is once again going to be from training. Now, we're going to increase our heart size, specifically our left ventricle. We're going to literally be able to pump more blood per beat, which means we've increased our stroke volume. Now, our heart rate, specifically our maximal heart rate, might actually go down a little bit if our heart gets to be that much bigger and stronger from training. Typically tends to stay relatively the same. Our cardiac output, so that's the total amount of blood we're going to pump around the body per minute, that's going to go up. The overall blood flow is going to go up. Blood pressure is probably actually going to come down a little bit because we're going to do a better job of vasodilating and sending blood to where it needs to be in the body. And our overall blood volume is going to go up. First, we're going to increase what's known as our plasma. So it's going to be the fluid, the water part, mostly of the blood. Then we're going to increase the red blood cell number. And that usually takes about a week for the plasma level to go up and about a month for the red blood cell level to go up. So at the end of the day, when we're talking about transporting, we pump it out of the heart, we go from our aorta to our arteries to our arterioles, and then we get that exchange in our capillaries. Now, the Fick equation is what we really care about when it comes to aerobic performance, because this is literally our stroke volume multiplied by our heart rate. So really it's our cardiac output multiplied by that AVO2 difference. So what type of athletes might have a really good stroke volume and heart rate, but what would maybe cause them to have a low AVO2 difference? So they're not pulling as much oxygen out of the blood, or they might not have as much in there in the first place. Who do you think that would possibly be?
The athletes that look cross country need to have like so variable the heart rate.
Swimmers.
Like when they are running, they have really high, and when they are not running, they have really low. And the ones that are not used to run are not as variable in the heart rate as the other ones.
Okay, now you guys are talking about great examples of people that are in shape. I'm referring to, think about places we could send you and or disease states where you would have a far lower AvO2 difference. So you're not extracting as much oxygen, or because there might not be as much oxygen to extract.
Like golf, you're talking about sports like that, like more passive, stagnant.
No, I said sports. So golf is not on the table in general. But second of all, cross country, how many of you guys know people that are anemic, or you've met somebody that had low iron? Anemia decreases how much arterial oxygen levels you can have. So you have a lower AvO2 difference. So they might have a great stroke volume and a great heart rate, but they're not carrying as much oxygen. So it's going to decrease performance. The other one is being at altitude, because you're not going to do as good of a job of taking up oxygen. And that's another thing that's going to take a hit to cardiovascular performance. So, Now, when it comes to heart size, this is left ventricular. Oh, there you go. I'll pull that up so you can see a little bit either. Internal dimension. So essentially it's gonna be the size of it. We can see runners, cyclists, and even strength athletes in general have a bigger heart. Same thing when we're looking at the interventricular septum thickness. So once again, how thick does it happen to be inside of the chamber? And then when we come down and we look at the left ventricular mass, you see the same type of greater advantageous change in cyclists and runners compared to strength athletes. And then left ventricular mass, once again, you see that bigger difference. Now, the reason we see a better change in heart size in cyclists compared to runners, and that is because cyclists don't have to deal with the impact and the bouncing and everything else that comes with it. Whereas they're in a nice position, which allows really good cardiac recovery and is going to allow them to have an even better performance effect. So your heart's going to adapt, because notice everybody's doing better than the control population they're being compared to. So in general, if your goal is to be in effectively a better physical condition cardiovascularly, you technically are the best. You technically probably want to be a cyclist, but no matter what, you're still going to be better than notice a control population. So the left ventricle is the one that's changing the most, because that's the one that's pumping the blood to the entire body. And we're going to see the internal dimension is going to be what increases the most, because we're going to be able to have that better stroke volume. We'll be able to fill it up better each beat. Now, the thickness of the wall is also going to increase because we're increasing the muscular side, the myocardium. So we're going to be able to pump with greater amount of force. So we're going to be able to eject more blood per beat, as well as filling more in the first place, which naturally gives itself the effect of increasing our stroke volume. Now, notice what we have here, guys, is stroke volume. It's in milliliters per beat. We can see how as we go from a low speed up to a high speed, this is going to keep going up to a certain extent, then eventually top off. And then notice it goes down a little bit in the pre-training. That's because at maximal heart rate, your heart doesn't have as much time to fill. So your stroke volume goes down a little bit. Mind you, that's only like the difference between being at 97, 98% of your max heart rate to 100% where we have this real loss. Whereas when we get to be more and more well trained, we're going to see this go up. And typically you're going to hit your peak stroke volume at about 120 beats per minute. If you aren't as well conditioned, as you get to be more and more well conditioned, then it's going to be happening more at like 140, 150 beats per minute. And that's why, go figure, if you decide to become more of an aerobic athlete, you've got to train at a higher and higher intensity. But this gives us good information, because if you're going to work with folks, you just need to get a good aerobic base on them, just to get the heart in better condition. You get those blood adaptations and maybe a little bit of capillarization. We just got to get that heart rate up to 120 beats per minute. So like Mark McLaughlin, and I use this protocol with myself on occasion, he'll have linemen get on a spin bike, put it on its highest resistance, put a heart rate monitor on them, and make sure they maintain that heart rate of at least 120 beats per minute while they're just pushing down against that max load slowly. We're talking 20 to 30 RPMs, but that's enough to cause positive changes in the cardiovascular system. And you're recruiting those bigger, more powerful type 2 fibers in the legs. So they're actually getting in better overall condition for the sport of football. And they're doing it literally by riding a bike. So, because if you think about it, let's take Nico, for example. Are we going to ask him to throw a baseball aerobically? How do you think your shoulders are going to like that one, bud?
Oh, they're going to feel worse than they already do.
Yeah, and we know you got some mileage on that body. So what would we want to try to do with somebody like Nico, where we're going to still use the muscles we're interested in, but we're going to get a little bit better aerobic adaptation to those muscles without adding even more damage to what he's already doing to his shoulders, elbows, everything else. It's just the joys of pitching. Nothing. We're just going to take him out back like Old Yeller and just put him down when he's gone too far. Sorry, that's a book here about a family that unfortunately has to put down the rabid dog, Alicia, if that reference doesn't work. It's okay. So, but think about relatively similar movement patterns. What can we maybe ask Nico to do to try to build that aerobic capacity in his shoulders a little bit more?
For the shoulders only.
Yep. Trying to think about pitching.
So do like many repetitions of some exercise, for example, 5 sets of 12 repetitions.
Okay.
Because
not a bad idea. You're looking more at muscular endurance as opposed to getting overall cardiovascular changes to those areas.
Yes. Aerobic is something also like doing with the shoulders, swimming.
Bingo. We could have something like swimming. Absolutely. We could have him do something like battle ropes and have him do those aerobically. Just make him do 10 minutes straight of not like he's trying to drum for a metal band, but instead making sure he's doing patterns consistently for 10 minutes, trying to do a lot of the same type of patterns that you're doing at that lower intensity, get those adaptations. We could, I don't know if you guys have seen a ski erg where it's you pull it down each time. Oh, I wouldn't punish him with it, but that is an option that you could have that's going to give you, once again, a little bit of those adaptations we're looking for, not just in the cardiovascular system, but those muscles he's going to use with throwing. But that's not something you're going to do in season, because then all of a sudden he's going to be spiking the ball into the ground and have really bad mechanics. This is something we do in the off season to just kind of help build some fitness. In fact, I believe it was, correct me if I'm wrong, Nico, but I believe Nolan Ryan was a giant proponent of swimming and everything throughout his entire career.
Correct.
Yeah. And when you're that good, there's probably a reason you're that good. So the stroke volumes, the amount of blood we're going to pump per beat, is definitely going to change as we go through training, both at rest and then at maximal heart rate. So individuals that happen to be at the greatest level, they in turn are going to have not just a much higher stroke volume, but their stroke volume at rest, so you guys just sit here in your chair, can be higher than other folks when they are running for their life at max heart rate. And then that stroke volume at max is going to be even higher still. You can see typically somewhere close to a doubling in a lot of folks. So now we're going to put you guys in a little bit of groups and hopefully have something that could be slightly misconstrued as fun. Okay. We're going to talk a little bit about effectively why muscle size can only be so big. Okay. So what I'm going to go ahead and have you guys do, I have my chat over here. Okay. Caitlin, you're going to go and talk a little bit about what's known as myonuclear domains. Okay. Alicia, I want you to talk about what's known as capillary distance. And then Nico, I want you to look into what's known as mitochondrial limits, or we can think of that as well as kind of just metabolic limits to how big a skeletal muscle, like individual fiber, can be in a human. Okay. So it's 6:28 right now. I'll give you guys about 5 minutes. So at about 6:33, I want you guys to paste in whatever you guys come up with. I want you guys to go ahead and use the power of the Google and anything else you guys want so that you can go ahead and explain to us what you came up with. And I will help you guys out if you're having issues with explaining this and why this all matters when it comes to effectively, how big can our muscles really get? Does that make sense, guys?
Am I doing the mitochondrial limits one?
Yes. Yeah. And think of it also as kind of energy limits. This one's going to cause you to think in ways that you guys haven't thought yet. And that's okay. It's all right to struggle. We're going to talk through it again make it about 6:34. Have fun. Sing loud, sing proud. Go ahead and say what you came up with. Excuse me.
Okay, so the myonuclear domains. Google said it's defined as a theoretical amount of cytoplasm within a muscle fiber that's controlled by a single myonucleus. So it sounded like this happens during hypertrophy, or whatever that word is. Hypertrophy.
Yeah, hypertrophy, bigger muscles.
Yeah, it says myonuclei are added to muscle fibers when increased in fiber cross-sectional area, and it varies between fiber type. But that's kind of all I got. I don't really know examples of it.
So one of the reasons why our muscles only get to be so big is because one thing that's fascinating about skeletal muscles, we can have more than one nuclei. They get multinucleated. Now, if you think of your nuclei in your muscle, those are the factories that are building the parts you need. But a better illusion I like to use is think of it as one farmer, okay? One farmer can only farm so much land, okay? Because by the time they've taken care of X amount of crops, it's just the end of the day. So if we wanted to take care of more land, we'd have to get more farmers, right? So if we go from just one farmer to two farmers, aka from one nuclei to two nuclei, we can in theory have a muscle twice the size, or fiber that's twice the size it was before. So if we can go from 2 to 3, well, now we can gain a little bit more size. And so the number of nuclei we have is a limiting factor on literally how big your muscle fibers can get. Now, the way that we increase the size of our, or the number of our nuclei, is by doing hard training and being male, aka testosterone, is actually going to activate and cause those nuclei number to increase. That's why when a guy is used steroids, they gain a lot of muscle mass because they're actually increasing their myonuclei, which arguably gives them an unfair advantage for literally the rest of their life, which then we can get into a really weird conversation about what that means for individuals that transition and how that's going to influence it. And same thing, if once an athlete's doped, they can't really hit the undo button. It's, well, Nico, going through puberty was freaking awesome from a muscle mass standpoint, wasn't it?
Absolutely. And I mean, I probably played with in my college baseball career. I mean, I'm not going to name drop people, but between 5 different schools that I've been to, probably at least 20 people who've been on steroids.
Yeah. I mean, because
I watched needle go in the butt, literally.
Yep. I have seen gentlemen, actually it was needle into the thigh is what I saw in my example, but that was hanging around power lifters and strongmen. That's, anyways, enough about drug abuse. Capillary distance. What did you come up with, Alicia?
The capillary distance are considered an important indicator of oxygen delivered to tissue. So that means that they indicate you the levels of oxygen. And when the levels of oxygen are lower, is because you are doing a high training and you are not using the oxygen. That means that you are using the anaerobic system and the ATP. And when the levels of oxygen are higher, is because you are doing an aerobic training and it's not as high as when you are with lower levels.
And another component when we're thinking about how big a muscle can be, on top of that, is the simple reality is if we don't have enough capillaries around this increasing fiber size, we just can't deliver enough nutrients to actually allow it to get any bigger. So we need better blood flow to that individual capillary so it has the nutrients it needs and we're able to get the oxygen and remove waste products to get to be any larger. So sadly enough, you do need a certain amount of cardiovascular fitness in order to increase muscle mass, as much as it hurts me to say that out loud sometimes. And the last one we've got is mitochondrial limits. Nico, what'd you come up with?
I have that mitochondrial function by activating mitochondrial biogenesis and possibly playing an important part in the beneficial effects of physical activity. Optimized mitochondrial function is strictly maintained by coordinated activation of different mitochondrial quality of control pathways. I was reading this article about it, and I'm trying to find this one part here, and it says excessive fission generates isolated mitochondria, which are less efficient at ATP production and are dysfunctional because they consume ATP to maintain their membrane potential.
Exactly. So it's kind of like the capillary thing where you just have a limit to literally how much energy the cell can produce to get it to be any bigger. So, you know, the reason we bring this up is it's important that we don't just understand like the box, aka, you know, the body, the muscles and everything else, but like, why is the box that size? Why can't we make the box bigger? What's getting in the way of making those changes? And so, you know, there is a limit. You know, that's the reason why humans are not the size of gorillas, because we have muscle physiology that is similar yet different enough that makes it harder for us to be those sizes, unless we're willing to use, well, witness things that Nico has seen. But let's say the syringe is going to be a lot more full and the uses of drugs are going to be a lot more exotic. So now what we have here, guys, is changes in our end diastolic volume, end systolic volume, and the ejection fraction from being untrained to being trained. And as you'd expect, we're going to do a better job of filling the heart. We're going to do a better job of emptying the heart. And because of that, we have a better ejection fraction as we go through training. So endurance training improves our stroke volume both at rest and every level of exercise from submax to max. Our end diastolic volume increases, meaning we're going to fill more blood in there. And we're going to, because of that, be able to pump more blood out. Okay. The left ventricular diameter is going to increase, as is, we're going to increase that myocardium size, so the muscle thickness, and we're going to have lower blood pressure in general, which in turn is going to allow us to pump more blood out as we go. So notice, guys, from pre-training to post-training, maximal heart rate in this condition from untrained to trained actually slightly goes down, but notice the total speed they can handle increases because they've had that gain in stroke volume. That's the real thing that's changing, increasing with training, whereas maximal heart rate can stay the same and in some cases, once again, go down. Now, your resting heart rate is probably going to go down. This is going to be because of we're doing a better job of feeding blood, so we've got that higher resting stroke volume and more sympathetic control or parasympathetic control. So we're going to see that individuals that start training can literally decrease that resting heart rate by about 1 beat per minute per week initially, and that you're going to see individuals that some have very much so smaller responses, and the total volume of training people do is going to actually, well, as you'd expect as well, massively increase or decrease their training effect. So some folks, when they say they're non-responders to aerobic training, it usually means they need to train more frequently. So there's some folks that only need to train once or twice per week, and they're going to be able to increase aerobic capacity. Some folks that literally need to train at least 5 times a week to improve their aerobic performance. And athletes that are incredibly well trained, we can see a resting heart rate that's literally, as I think the lowest is usually I've seen is like 27 beats per minute at rest, because their heart is that well trained, has that great stroke volume, how small their frame is, that it can run that low and then be able to perform just incredibly well. So our submaximal heart rate, so when we're just doing the same amount of work at a fixed like walking speed or slow jogging speed, is going to go down. Okay. This is going to increase obviously over longer periods of training. And remember, maximal heart rate isn't really going to change too much. If anything, it might go down a little bit because we're still maintaining that much better stroke volume. So we just need more time to fill the heart completely. Now, heart rate recovery period is how long it takes from the end of exercise until your heart rate gets back to resting. Okay. As you get to be in better and better shape, this is going to drop down a lot more quickly. And we can use this as an indicator of how well trained someone is. Now, if we're dehydrated because we've been lifting in the heat, or we're at altitude, so we have that lower AVO2 difference, we're going to see this also not work as quickly. But what's really important is we look at how an individual changes. So if you have the ability to put a heart rate monitor on all of your athletes, what you could do is literally see how quickly they recover from a given sprint, or, notice is like a 4-minute effectively all out effort. And the faster they recover, in turn, you can go ahead and program them their next sprint based upon when their heart rate is ready. Now, this is one of those things, you got the money, you got, the budget for the equipment, and you've got that level of athlete, because you can't really fake a high heart rate. It's either high or it's not. But what this is really useful for is, I'm sure all of you guys have played a sport where we all conditioned as a team. So we had a sprint, stand there, we had a sprint back and stand there. You had certain teammates that were in such good shape, they're barely out of breath. Like, they do the sprint, we're all tired, but by the time it's ready to sprint again, they're like, okay, cool, whatever. And they don't really get into it. So this allows you to set that conditioning based upon their own recovery. So if being a little bit better condition would be useful for them, this is a good way to go about trying to establish that and effectively allow those athletes to train at those higher intensities and the shorter recovery period, so they can once again do more work. Okay. Alicia, do you guys do this at all with track and field? Kind of anything on the heart rate recovery, or they just kind of give you guys long rests and you go when you go?
They give us, now we are with not too much recovery, instead of 90 seconds and 5 minutes.
That's a bit of a
Because
gap.
we are all working like on the pre-season, so I think that because of that. But I'm used to have much more recovery than here.
Yeah. Hey, I hope you survive. And those can be useful to have that bigger metabolic effect. So, time and a place, and you need to understand why you're doing things. So notice, guys, when we look at that heart rate max going down a little bit, but stroke volume going up, look at the overall effects and that increased cardiac output as an individual goes from being untrained to trained. So we're going to increase the number of capillaries. So that is the amount of actual blood flow we have to those individual fibers, thanks to training. We're going to do a better job of opening the capillaries we have through vasodilation. So we do a better job of sending blood flow to that area. And we're going to be able to vasoconstrict the areas we don't need it. So we're going to do all over a better job of sending blood where it needs, as well as just increasing our blood volume. Now, doing aerobic style training tends to actually have positive effects on your blood pressure, especially at rest. Your systolic is going to go up because your heart's pumping with a little bit more force. Your diastolic might go up a little bit, might go down a little bit, might stay the same. Doesn't really change too much when you're doing aerobic work. When you're doing things like resistance training, especially if you're doing the Valsalva maneuver, that blood pressure is going to shoot way up in both the systolic and the diastolic because you're bearing down, increasing, and so you've got better core stability. And like anything else, this can be a decent adjunctive therapy, or essentially a primary therapy for controlling blood pressure, especially individuals that are sedentary. Now, this is the way that your blood's going to adapt to training. Notice in that first week, we get this increase in our plasma volume. And that is because we're going to increase the amount of albumin, along with we're going to carry a little bit more electrolytes. So we're going to essentially have a greater fluid side of the blood. It takes about a full month for you to have that increase in your red blood cell volume, which in turn, now that you've got that greater red blood cell volume and greater blood volume in general, we're going to do a better job of having that better oxygen carrying capacity. So if we're looking at pre-training to post-training, we see technically our hematocrite's gone down because we've increased our plasma so much, we've kind of diluted the red blood cells, but we're having a better stroke volume, we've got lower resistance, and we're going to have better blood flow that it's actually going to be useful. So really hard training is going to increase our blood volume. It's going to happen mostly by increasing the plasma volume, which once again is due to proteins like albumin. We're going to then see an increase in the red blood cell count. That's thanks to the hormone erythropoietin being released from the kidneys when they detect a lower oxygen carrying capacity inside of the blood, which in turn is going to tell our bone marrow to produce more red blood cells. And as we're going to decrease this blood viscosity, because it's essentially a little bit more liquid, we're actually going to be able to pump it around the body more efficiently, which in turn is going to enhance how much oxygen we actually are going to deliver. And these are going to be obviously related to improvements in both our stroke volume and the overall VO2 max. So left ventricle is going to increase in size, and the myocardium is going to increase in thickness. Right ventricle is going to increase in size. Myocardium might increase a little bit in thickness, but there's nowhere near as much pressure required to pump the blood through your lungs as it is through the rest of your body. Our stroke volume is going to change at every single level. Maximal heart rate is going to stay the same, maybe go down a little bit. Cardiac output is going to be better in general, and we're going to do a better job of sending it where it deserves or it needs to be, and not so much where it doesn't need to be. Blood volume is going to increase, and then red blood cell, but it's going to take about that full month and to a lower extent. And our overall blood pressure is not going to change too much, might go down slightly, and especially more importantly in disease populations, as well as we're going to see that systolic blood pressure going up as our exercise intensity goes up, unless we're doing resistance training, everything's going up. And our diastolic typically is going to stay about the same. Now, another big component is when we think about what is going to be that lactate threshold. So remember again, guys, lactate is that essentially a carbohydrate that's been partially broken down because we don't have oxygen available inside of our cells. Now, we're going to look at it from a couple different ways. One of which is going to be the respiratory exchange ratio, the RER that you guys saw in the VO2 cart. This is giving us an idea of which fuel our body is using preferentially. Now, we're going to be able to utilize fats for longer as we get to be more aerobically trained. And then we're going to obviously transition into aerobic glycolysis, and we're going to be able to get to a higher intensity before we really start to have the accumulation of lactate in the bloodstream. Now, we're going to see that our total oxygen consumption at rest is going to stay the same, might go up a little bit, might go down a little bit, especially if we lost a lot of weight due to our training. Now, it's going to stay about the same at sub-maximal exercise, might go down a little bit because we become more efficient. What we're going to find is our max, our VO2 max, is going to increase. And thanks to genetics, that's where we can see close to a doubling in some people. Other folks might not see much of a difference whatsoever. Once again, sadly enough, it's who your mom and dad are is going to really influence your chances for being a better aerobic athlete. Because yes, if you're already in good shape, we're not going to see as much of a change in VO2 max. If you're untrained, we're going to see a much larger change. If you happen to have, once again, who your parents are, that's about 50% of your response. Age, as you increase in age, you tend to have a lower response to aerobic training. In general, women are going to have a lower adaptation than men. And that's more probably just due to body compositional differences from gender. And you're going to increase your VO2 max the most when you're specifically training it for the way you're tested. So there's always going to be this specificity. Okay. So what we have here, guys, is trying to hold on as we get older. Okay. If you're still training hard, okay, you can still maintain, if not even slightly increase your VO2 max. Notice, guys, all the way in your 50s. Now, it's once we get into our 50s and 60s and 60s and 70s, you're going to go down. The key is how much you're going to go down is going to be relative to, are you still getting after it or have you given up? If you're not training anymore, it's going to go away. If you're still training, you're going to maintain a certain degree. Now, when we say specificity, notice what we have here on this side is uphill treadmill running, and then the other side is the actual sport-specific activity. Notice how these rowers, this guy had a VO2 max of almost 75, but when you put him on a treadmill, he didn't get to 65 because it turns out rowing is not the same as uphill running. And then same thing, when we look at the skiers, it's a little bit closer in general to the line as it is for the cyclists, but we're always going to do a better job at whatever we're doing aerobically. Now, that being said, think of our cardiovascular system as three major parts. We've got the pump, the heart, the pipes, which is your vasculature, arteries, arterioles, veins, venules, capillaries, and then we have the fluid, that's blood, okay? Two of those are going to be general, meaning you're using them no matter what you're doing. One of them is going to be specific to what you're training, okay? What's the one that's going to be specific to what you're training?
Will you repeat that?
Yeah, no worries, Caitlin. You've got the heart, the vasculature, and the blood. Two of them are going to be general, meaning they're going to adapt to whatever training you give. Doesn't matter if you decide to do long distance swimming, running, biking, skiing, whatever. One of them is going to adapt only specifically to that modality. What's the one that adapts only specifically?
The heart.
The heart, that's what I was gonna say.
Heart's going to be general, pumps blood everywhere in the body. The key is what? What's going to be specific?
The flow.
The capillaries, the vasculature, that's what's going to change specifically to your training. So this gives us really two important takeaways. One, if we want to get better at something, we need to do it. Does that make sense? You're not going to become a better long distance runner from doing long distance swimming and vice versa. Okay. The other is if you just want to have a better heart, so you're less likely to have a heart attack and just overall better function, just do something aerobic. So you could do it through cycling, through swimming, through walking, through running, through hiking, through hula hooping, if you can get your heart rate high enough. The key is that blood and that heart is always going to adapt to aerobic training no matter what. It's only going to be specific adaptations to that vasculature. So for overall long-term health, you just got to find something you like aerobically and do it. That's it. Could be dancing. Get after it. I don't care. Have fun. Okay. So this slide is really important when it comes to understanding the cardiovascular system. If you understand the slide, you understand essentially the entire cardiovascular system. Notice what we have here. This has got training for long-term endurance is going to be in yellow. I'm sorry, the contrast really sucks, but we can see how we're going to have these changes for both submax and true VO2 max performance of how our body's going to change. Take your time on your own, look through it. If you have questions, we can always come back to it on another night, but making sure that you understand how this flows. Now, the next thing we've got is effectively our breathing. So we're talking pulmonary. So how we're going to bring in oxygen and remove CO2, what's going on with respiration and just general gas exchange, and then how we're going to regulate this, as well as how it's going to be potentially a limit to our physical performance, and how we're going to use breathing as a way to maintain our acid and bases. So pulmonary ventilation is the literal act of breathing in and breathing out. Pulmonary diffusion is literally going to be the gas exchange from the alveoli into the capillaries of the lungs. So we breathe in through our mouth or our nasal system, down the pharynx, larynx, trachea, bronchi, bronchioles, into eventually these alveoli that have really, really great vascularization. So we're going to have really good, essentially, blood flow to the area, which in turn is going to give us a better job of taking up that oxygen. Now, our diaphragm is going to pull down in order to create a negative air pressure in our lungs, which is going to pull air into our lungs. So you can see how it goes down. We have that lower air pressure, which is going to pull air into our lungs. And then whenever we exhale, it's going to come back up. We can also use muscles like our abdominals, QLs, and lats in order to help push the air out. We can use our scalenes, our pec minor, and our SCM, sternocleidomastoid, in order to breathe in a little bit deeper. So pulmonary diffusion is going to be that actual gas exchange from the alveoli into the capillaries. This is where we're going to get our oxygen in. We're going to remove CO2, and it's a really, really thin membrane. So if we're looking at the alveoli, zooming into one of them, we can see those capillaries on every corner. This is literally cells that are essentially flat as they can pretty much darn near be. So on the other side, that's going to be like the red blood cells in the capillaries. We're going to have the O2 going out to it and the CO2 being removed from it. Now, there's a couple laws of gases that we need to know about. Dalton's law and Henry's law, okay? Dalton's law is pretty simple in that the partial pressure of individual gases that are in the air will always add up to the total pressure. And then Henry's law is that gases are going to dissolve into liquid in proportion to their partial pressures. So normal standard air pressure at sea level is 760 millimeters mercury. The air that we're breathing right now, guys, is a little over 79% nitrogen. about 20.93% oxygen. And then the leftover is about 0.03% carbon dioxide, getting closer to 0.04 thanks to the joys of global warming and climate change and the joys of carbon production throughout the world. Now, notice when we think about Dalton's law, this is the partial pressure of nitrogen, the partial pressure of oxygen, and the partial pressure of carbon dioxide. So effectively each gas has its own solubility, and that pressure behind it is going to be pushing or pulling that gas in or out of effectively the bloodstream. So if we are going to look at the partial pressure of oxygen inside of the alveoli, it's usually about 105. The reason it just dropped from being, notice guys, like 160 down to 105 is because the air in your alveoli is incredibly humid. So it's that H2O that causes it to drop. Carbon dioxide is actually going to be about 40, and that's because we're releasing it consistently into the alveoli. And so the partial pressure of oxygen in venous blood coming into the lung is going to be only about 40, and for carbon dioxide, it's going to be about 46. Then that gradients are going to push and pull things accordingly. So we're going to leave at about 100 millimeters mercury of oxygen and about 40 for carbon dioxide. It's going to go through the body. And when we pass through our cells, that's where we're going to take up a bunch of that oxygen. So that's that AVO2 difference. We went to 100 to 40, so it gives us an AVO2 difference of 60. And carbon dioxide, we're going to be adding a grand total of 6 millimeters mercury. So we have the air that we're breathing in that's dry. Then it gets into the alveoli, and you see this massive jump right here, guys, in the water levels. And so when we get to our venous blood, in turn, you can see this gradient we're going to naturally have between oxygen and carbon dioxide. Nitrogen is not something we're really trying to take up, though. If we have excessively high levels, thanks to being at really high air pressures, that can give us things like the bends, and that is definitely something to avoid. So pulmonary diffusion is going to be how we're going to exchange those gases through those thin membranes. Now, how much exchange is going to be based on that partial pressure each of those gases have, and the gradient, where we're going to typically always go from high to low. Hence, carbon dioxide leaves, oxygen enters, unless you're breathing some really weird air. Okay. This oxygen diffusion capacity is actually going to go up as we go from rest to exercise, because we're going to do a better job of lowering the oxygen level that's returning from the mixed venous blood. And the CO2 pressure gradient is much smaller, but carbon dioxide is far more soluble, meaning it's going to cross that membrane with much, much greater ease than oxygen, about 20 times greater. So oxygen, once it's in the bloodstream, is going to be bound up to the protein hemoglobin inside of red blood cells for the most part. Now, the amount of protons available, so the pH as well as temperature of muscle, is going to cause a greater amount of oxygen to potentially be delivered to those areas. And as you'd expect, training is going to influence it. So what we're looking at here is what's known as the oxygen hemoglobin dissociation curve. This literally means how easily or how difficult it is for hemoglobin to let go of oxygen. At the bottom, we see the partial pressures, okay, of oxygen. And then on the side, we see how saturated hemoglobin is. Now, when we're looking here, as far as our saturation and the total partial pressure of oxygen, what do you see happens whenever pH goes down or temperature goes up? What's going to hit curves whenever pH goes down or temperature goes up?
The partial pressure increase, and so does the saturation percentage?
So it's actually going to cause the red blood cells to unload oxygen at a faster rate. See how it's the hemoglobin saturation. So it's going to really let go a lot faster at a higher temperature than a lower. And at, you guys see low blood pH, so it's more acidic. It's going to unload it a lot faster. Okay. Why would that be useful?
Or know the levels of exercise, like how is training a person, because when you have high levels of pH, I think that is because I think it's something of the lactate, and I think so.
Okay,
I'm not
it's going to be lower pH when you've got a lot of the lactate. Good.
okay.
So your pH and the temperature in exercising muscle, the pH is going to be lower and the temperature is going to be higher around exercising muscle, which means we're going to naturally give up oxygen at a faster rate, which is a good thing. Whereas our lung is going to have a higher pH and a lower temperature. So we're going to do a better job of pulling oxygen in once we get in those areas. So now we have myoglobin versus hemoglobin. And myoglobin is that protein in muscle that is going to bind oxygen and then deliver it to the mitochondria. Notice it is going to hold oxygen much harder. This is good because it literally is going to take the oxygen from the bloodstream, from hemoglobin, and then drop it off in the mitochondria, because really the mitochondria's oxygen saturation level is pretty much zero. It's using it pretty much as soon as it gets it. So you want it to be able to grab it much more robustly, but then obviously drop it off at the end. So what we have here is the AVO2 difference between what would effectively be a going through capillaries that are not being very metabolically active or relatively sedentary, because you see we've only pulled off 4 to 5 milliliters of oxygen. Whereas when we look at those capillaries in exercising areas, we can see that we're pulling off near or pretty much 3/4 of it. So we're talking about 15 mils. So how much oxygen we're going to deliver is going to be influenced by obviously how much oxygen we have in the first place, how much blood flow we have in the area, and then really what's going on in that muscle. So carbon dioxide is going to transport in kind of some interesting ways. It's not just going to be delivered as just plain carbon dioxide. It's actually going to essentially turn into what's known as bicarbonate, and also dissociate because of dissociation with bicarbonate ions. And that's about 60 to 70%. And then a certain amount of that carbon dioxide is actually going to bind to hemoglobin, which creates what's known as carboamino hemoglobin. And that's about 1/5 to 1/3. So when we're looking at this respiration, this slide is just a useful way that you guys can see. We top it off in the alveoli. We then pump it. It comes back to the heart, leaves the heart. So we haven't lost any oxygen. We haven't gained any carbon dioxide. Then we get to our actual tissues. And that's where we're going to pull a whole lot off. And then now that we've increased our carbon dioxide a little bit, we really decreased our oxygen levels. And that's going to go to the heart, pump through the pulmonary arteries, and then we're back to the alveoli topping off again. So oxygen is really just being transported around, being bound to hemoglobin. Small amounts going to be dissolved in blood plasma. Hemoglobin is going to find changes in its saturation whenever we've got a lower pH or a higher temperature. This is going to allow us to unload it faster, which is the advantageous effect when we're around those muscles that are being metabolically active, because the temperature is higher, the pH is lower. Then hemoglobin itself is really going to typically be very high. It's actually hemoglobin saturation is something you hear a lot when it comes to things like COVID. And for the most part, we just want to make sure that we've got more, obviously, than enough, or at least definitely enough. And it turns out we're going to rarely have an issue with the oxygen carrying capacity is the limit. It's instead going to be how quickly we can deliver the oxygen to the area. Carbon dioxide is mostly being transported around as bicarbonate, a little bit as carboamino hemoglobin, and then obviously the smallest amount is truly dissolved carbon dioxide. That AVO2 difference is literally how much oxygen we're able to take off from the arteries to the veins. And the higher that is, the better job we're going to be working metabolically. And we're going to see the same type of exchange when it comes to CO2, except that it's going to be leaving the muscle, and entering the bloodstream and then leaving into the alveoli back into the air. Now, our breathing rate is going to be regulated by our brain itself, chemical changes inside of the body, and which can be done thanks to chemoreceptors, muscle mechanoreceptors, so that we're producing force, the body is noticing that, as well as hypothalamic input and a little bit of conscious control, meaning we can always control our breathing. We can hold our breath, we can take in a deep breath. And you guys been around a little kid when they literally hold their breath enough till where they pass out? I haven't seen it, but I hear about some folks. I mean, that's pretty impressive that somebody can hold their breath until they black out. But we have all of this information. We have this input. So really, the major, if you guys see here, the central chemoreceptors is based on how high or lower pH is. So lower pH, we're going to breathe faster. Higher pH, we're going to breathe a little bit slower. And actually carbon dioxide levels. So when our CO2 levels get to be really low, we have a lower desire to breathe. And obviously when they're higher, we have a higher desire to breathe. And then it's rarely going to be based on actually how much oxygen we have. Now that we do have those peripheral receptors where we do have the ability to sense partial pressure of oxygen, still carbon dioxide, and the pH, and muscles themselves are all going to give information into the inspiratory system. And you see how we've got the pons and the medulla oblongata. This in turn is going to activate our diaphragm, our secondary breathing muscles of our external intercostal muscles in order to get us to go ahead and breathe in. And then on the breathe out, we have stretch receptors, which you guys have probably noticed if you're ever driving down a road and you're just getting the air blasted in your face and it's hard to take a breath in because the lung doesn't want to be overstretched, because if you blow out a lung, you're kind of screwed. And then you've got your intercostals and abdominal muscles, along with the latissimus dorsi and the QL, which are going to be accessory muscles for exhalation. And as you suspect, guys, as exercise intensity goes up, your breathing rate's going to go up, both in the total amount of volume you're taking in per breath. So that's going to be tidal volume, so that's what's referred to, in the frequency of your breaths. And that's how many you're doing per minute. Now, there's a couple situations where it's a little bit different. This can be things like dyspnea, so it's the shortness of breath that happens to most folks, and that's because of issues with carbon dioxide and hydrogen levels. Buttons aren't toys, Mike, don't hit the wrong thing. Hyperventilation, where people are going to breathe way more than they should, and that's because they're stressed out. And this in turn is going to cause the blood pH to actually go up because we're actually becoming more basic, and we're going to lower our partial pressure of carbon dioxide. Some folks can also pass out because of this. And then we've obviously the Valsalva, where we're going to hold our breath and bear down. So we're going to build a little bit more essentially stability throughout our core, which is going to help with keeping us safe with heavy lifting, but isn't a really great long-term methodology. You can only do it for a couple seconds. Now, ventilatory equivalent for oxygen is just going to be the ratio between our ventilation and the total oxygen we're getting in at a given time. Okay, so it's really how efficient we are with breathing. What we want to see is that we're effectively breathing in a smaller amount of total air for the amount of oxygen we extract. Now, when we get up to maximal exercise, we're actually getting a little bit less efficient because we're just breathing off a lot. And a lot of it is just buffering out the carbon dioxide, and the bicarbonate actually helps a little with pH balance, which we're going to get to in a little bit. Now, the ventilatory break point is the point at which your ventilation rate goes from moving up relatively evenly to now increasing pretty quickly. This is also referred to as the point of where it becomes a lot harder to talk. And this is your last ditch effort to try to buffer out the anaerobic component of essentially the extra lactate and the extra proton that came with it that's dropping your blood pH thanks to the hard training you're doing. So what we have here is just the general oxygen uptake that someone's going to have, and then the breathing rate, where you're going to see that boom, that second slope, because now they're just trying to buffer that out. And you guys probably naturally felt that when you guys were doing the wonderful firefighting lab, climbing that mountain of nowhere, and you're like, I am breathing a lot faster now, and I will not be talking to anyone because I got to focus. And that's usually right when we're hitting that lactate threshold as well, which we refer to as the anaerobic threshold. And this is where now our body is having to use much more anaerobic glycolysis than it was before. And it's specifically the point at which we're going to now start to have accumulation of lactate in the bloodstream. Okay. Notice, guys, this is where we're going to see an increase in the total amount of ventilation without an increase in the total amount of oxygen we're getting in. So we're effectively becoming less efficient with our breathing. So you can see how we go, and then like, what? So we're breathing faster, and we're actually keeping that carbon dioxide intake about the same, if not a little bit better, but we're now actually taking in nowhere near as much oxygen for the total amount of breathing we're doing. So respiratory centers in our brainstem, remember that pons and medulla oblongata are going to set the rate and depth of breathing when we're not consciously thinking about it. We have those chemoreceptors inside of the brain that's detecting carbon dioxide levels and blood pH. They're going to cause our breathing to go up when those levels are going to increase, okay, both carbon dioxide and protons. And it's going to obviously go up with exercise and a little bit of just the neurological preparedness. So if you realize you're going to start exercising, your breathing rate's going to actually naturally start to come up as a means to prepare you for it. So there's a couple different breathing problems. We're only touching on a couple basic ones. There's asthma and obviously a lot of others that bother a lot of people. We're going to find that our body is going to typically take up exactly what it needs. So we're going to find that the rate at which we're breathing is going to always relate to the amount of oxygen we're using. We're going to hit that point at which where we're not going to be as efficient with oxygen because we're trying to buffer out that carbon dioxide that comes with it. And that anaerobic threshold is identified as a point at which that total ventilation is breaking away from the total amount of oxygen we're taking in. So what's going to limit us? Well, in reality, your diaphragm and all the other muscles that are involved in breathing are going to take energy. So when we happen to be doing really hard exercise, there's a chance you might actually start to be fatiguing out your secondary breathing musculature. And so you're not going to be able to keep it up. You're not going to just work so hard that your diaphragm can't keep up and it just seizes and you die. Like that's not how this works, hopefully. Instead, you're going to be overworking to where it can't go any faster with rate if it wanted to. So it's going to be rarely ever a limiting factor unless we're talking about some insanely highly trained long distance athletes. And airway resistance and gas diffusion is usually not a limit either, unless we've got some type of abnormal or obstructive respiratory disorders. And I'm sure all of you guys, through the joys of the wonderful mask wearing that we've had to do over this past couple of years, have realized like, yeah, wearing the mask does put a slight damper and make things a little bit more difficult. But are you going to die from it? No. Does it make it more challenging? Absolutely. So whenever we've got greater amounts of protons, aka lower pH, we are not going to be able to literally produce energy as well. The enzymes of glycolysis are going to shut down. They're going to unfold a little bit and they're not going to work. So our body is going to try to regulate this by increasing our breathing rate because we're going to have a greater amount of carbon dioxide converting into bicarbonate, which in turn is going to allow for a buffering capacity because these protons are going to bind to bicarbonate. So they're not going to be free floating, instead causing our proteins to unfold and binding to them. So we have our pH that we're trying to maintain in both our arterial blood and in our muscles. And we get to be too low, we're either going to vomit if it happens to be your blood pH, or your muscles are just going to not necessarily seize, but you're not going to be able to produce any more energy. So you might be stuck in spasm, or either way, you can't produce force like you once wanted to. So when we say buffering, okay, we see here a salt solution. So it's got sodium chloride, table salt. We add hydrochloric acid. We've got one proton free floating and a chloride. So effectively, we've now made this fluid a little acidic. Now, if we throw bicarbonate in here and we add a chloride to it, you're going to see how now we're going to have a negative charge and a positive charge. So we're going to actually have that proton taking up because we're going to convert this into carbonic acid. So it's not going to be free floating anymore. Instead, it's going to be bounded up. So what we're going to see is this type of interconversion between bicarbonate, proton, and, carbonic acid, hydrogen, bicarbonate. So as we're going to exercise, we're going to start to switch our body into a more acidic environment. So we're going to be converting more here. However, if we happen to vomit because our pH gets to be too low, we're actually going to be losing a lot of hydrochloric acid, which in turn is going to be moving from our bloodstream into our stomach, and that solves the problem. It's very unpleasant, but it is a solution to the problem. And so our respiratory control, we're going to see that we've got a greater amount of carbon dioxide. So we're going to be getting a greater amount of carbonic acid. And we're going to see as this pH goes down, because we've got bicarbonate and proton, we're going to breathe. We're going to tell the body to breathe more. This causes the rate and depth of breathing to increase, which in turn is going to give us to eliminate more carbon dioxide, which is going to get our pH back up a little bit more. Now, the last concept we have, because we touched on it way earlier when we talked about the effects of the sympathetic and parasympathetic nervous system, on your heart rate. And that gives us what's known as heart rate variability. And heart rate variability is literally just the little minute differences in your heart rate on a beat by beat basis. As we breathe in, we are going to be creating a little bit more pressure in our chest, which in turn is actually going to cause our heart rate to go up just a little bit. As we breathe out, we're going to create a little bit less pressure in here. We're going to get a little bit more vagal tone from the parasympathetic nervous system, which is going to cause our pH to go down, or our heart rate to go just down a little bit. And this is going to be different for each individual. But what we're going to find is a greater amount of heart rate variability within healthy individuals is in turn going to be a good indicator of someone's overall recovery. Meaning, if we've got a greater heart rate variability, that means that our body is in a greater amount of parasympathetic tone, which means we are more well recovered overall. And you guys can kind of see how we have this entire feed forward mechanism from our higher brain to our feared centers and our more lower brain, which is going to influence our hypothalamus and our brainstem, which in turn is going to either cause parasympathetic system to be down-regulated or up-regulated. So down-regulated if we're talking about essentially a higher heart rate and a lower heart rate variability, and an activation of our sympathetic nervous system increases our heart rate, as well as it is going to cause a decrease in heart rate variability. This is an important thing because this is a very up and coming concept when you're working with athletes as a good marker of athletic recovery. And you're going to find athletes that are sick, overreached, they are going to have a greater heart rate variability. And in turn, that means their body is not as ready for more stress that day. So we have to be careful with how much work we are giving them. Okay, we covered a lot of ground tonight. You guys have got an exam coming up literally next week. Eesh. What questions you guys got for me?
I just have like a random question that I thought about when we were talking about the respiratory system. But like, if someone had COPD, would like cardiorespiratory endurance training, like mild, would that hurt them or help them?
Ooh, so the big key is always keep in mind an individual's ability to adapt to the demands placed on them. Everyone typically has a certain amount of adaptability, but the key is you want to be reasonable with what can they really recover from, and are they going to be able to effectively adapt in a way and they're not going to get hurt with the training.
Yeah.
So individuals that have got like end stage COPD, it's kind of sadly enough, it's too late.
Yeah.
Might not be able to
That's
do
what I
anything
thought.
with it.
I thought
Yeah.
I'd ask.
No. It's a good question worth asking, because some folks, they're going to be able to, get after it and keep going and, tear it up late in the life. Other folks, it's not going to work like that. And we got to be careful with effectively, are we asking them to do too much work?
Yeah. I know when I did my internship, there was this patient who had COPD and was like on 4 liters of oxygen a day, and he was still, or they were in cardiac rehab, and I was just like, oh my gosh, like they could barely do anything. Like they had to take breaks and they had oxygen, and I don't know. That was why I asked that.
Yeah. No, I mean, that's the thing is if there's still a chance, do it. You still, because the human body is meant to move.
Yeah.
Obviously we can move too much that we cause damage, but we want there's a negative amount of damage. We want a certain amount of damage because it's telling us to get better. And so if there's still some adaptability, go for it. But that's why, you're really, I know Alicia already talked about how she doesn't want to have to run a quarter mile, but these people don't even want to walk a quarter mile. Well, you've seen it. So you got to meet them with where they're at and not go too hard. I brought up the next lab you guys are going to do because that's the velocity load relationship. So you guys are going to be using what's known as the gym aware. When's a good time you guys want to come in and we can have you guys go ahead and, get oriented on how to use it. And then we can effectively look at what is the total amount of, or you guys can be able to look at the velocity of whatever movements you guys want to look at. And Nico, feel free to recruit friends from the baseball team that feel like doing a little bit of bro lifting. If it's okay with your coach, same thing, Alicia, because effectively this next lab is actually going to be fun because we're going to get you guys on the gym awares and we're going to have you guys look at, literally how fast you're going to move different implements when it comes to the training you guys are doing. So
Is this lab like we
campus-
have multiple days to do it, or is it kind of one day?
You can probably bang it all out on one day, but like anything else, you guys probably want to split up your testing over a couple days. And I'm going to at least show you guys how to use everything first. So what is your guys' schedule like this week that we can kind of get everybody to come through? And I'm going to hit stop